tech issues, and we are so excited to have this conversation with you both. It's well needed in the conversation that we are having amongst the endo and pelvic pain community at the moment. So it's so great to have you all here. And I just would also like to welcome all of the people who are joining us here tonight. My name is Jess Taylor. I am the CEO of QENDO. It is excellent to be here. We've just come back from Canberra from an amazing expo and extraordinary parliamentary event to raise awareness and action about endometriosis. We talked about the need for ultrasound Medicare item numbers, amongst many other things. So we are creating action where we can. I also can see Alison Mander online, which is really wonderful. Welcome, Alison. So many other great people here tonight. Thank you. So I would first of all just like to acknowledge the traditional lands that we are all meeting on today. I am meeting and coming from the Quandamooka people, Quandamooka land, and also like to pay my respects to any elders past, present or emerging. And also note that and take respect to the thousands and thousands and thousands of conversations they've had over so many years from those communities and those cultures and different tribes, and note that that's what we're continuing to do here today with an hour with QENDO, where we talk through key issues from the community and look to bring experts in the space to share knowledge. I'm welcomed here tonight by two Jackies, Jackie Kingsley and Jackie Chua. Jackie Kingsley is the lead gynae sonographer from Queensland Ultrasound for Women. And we also have Jackie Chua, who is an obstetrician gynecologist specialist ultrasound doctor, or for those in the room, an ultrasonologist, I believe I've got that correct, perhaps. Thank you. And we've really wanted to crack open this conversation about the role of ultrasound with endometriosis diagnosis, adenomyosis as well, I'm sure goes into the mix, and really talk more about what do we mean by that. And we've said for many, many years, an ultrasound, endometriosis cannot be detected on an ultrasound. And so we're all a bit confused because now we're saying, hold on a minute, we can. And why is that so? So we're really hoping out of the discussion tonight to give some understanding to the wider community about the differences of ultrasound and what is that role of ultrasound when we are talking about an endometriosis diagnosis or picking that up to form that clinical picture. We welcome your questions. So please pop the questions in the Q&A, and hopefully at the end we will have some time. If we don't get time, we will hopefully work with Jackie and Jackie to answer some of those questions. We are recording this webinar because we will produce this as a module in the Manage Endo program. So if you would like to remain anonymous, you are welcome to do so. Just change your name in your Zoom title. Well, thank you so much for joining us. And again, like I said, this is a conversation that is so often discussed, and unless we get education out to the community, we'll remain confused. I myself have taken quite some time to get my head around the fact, okay, we have new technology, we have new techniques, so it's really time to move this conversation forward. I look forward to hearing from you, and we will be monitoring the chat. Ash is online as well, and please feel free to reach out to us if you do have any technical difficulties during this evening. I'll hand over to Jackie Kingsley now and Jackie Chua to kick off an hour with QENDO. Thank you so much for joining us.
Thanks, Jess. Thanks, Ash. Hi, Jackie. Can you all hear me?
We can hear you.
Oh, great. Well, I'll get started. I'm going to start off by talking about endometriosis. So endometriosis is a chronic inflammatory condition affecting 1 in 7 women and people assigned female at birth. Patients can be asymptomatic or have debilitating symptoms: pelvic pain, heavy bleeding, pain during or after bowel motions, painful intercourse, pain with urination, chronic lower back pain, and also fertility concerns. The average Australian with endometriosis experiences a diagnostic delay of 6.4 years. This diagnostic delay has a flow-on effect, with 30% of women with endometriosis experiencing infertility, and up to 50% of women with infertility are diagnosed with endometriosis. So a number of studies suggest family clusters of endometriosis, suggesting it can be genetic. So there's an increased risk possibly if relatives, mothers, sisters or aunts have had endometriosis. So why is there a diagnostic delay? So period pain is often dismissed as normal. There's frequent misdiagnosis, starting at GPs, imaging, whether it be ultrasound or MRI or other technologies, or laparoscopies. There's a delay and wait list for surgery in the public system, and the private system is expensive. There's also not enough trained gynecologists or surgeons to be able to perform the deep endometriosis surgery. And there's not enough trained sonographers to perform specialised endometriosis ultrasound. Finally, there's not enough specialists or doctors able to or proficient to report endometriosis ultrasounds either. So what exactly is it? It is a condition where cells similar to the lining of the uterus, the endometrium, implant outside the uterus. Implants respond to hormonal fluctuations with proliferation and secretory activity. It's estrogen dependent. Just as the lining of the uterus thickens and bleeds every month during menstruation, so does this tissue. This causes inflammation, swelling, and pain in these areas. This inflammatory response causes the fibrosis and adhesions that lead to the alteration of pelvic anatomy, creating a chronic inflammatory response. Endometriosis is located on the ovaries, the fallopian tubes, the surface of the uterus, the bowel, and the peritoneum. Less commonly, the vagina, the cervix, the bladder, the upper abdomen, including the diaphragm, and surgical scars. Most common site for deep endometriosis is the uterosacral ligaments and bowel, that is the rectovaginal and rectosigmoid area.
So normally we talk about actually the types of endometriosis. The most common or the easiest thing to actually see on scan is actually endometriomas, when it actually affects the ovary itself. That is actually pathognomonic for endometriosis. Next part, thanks. The next is actually superficial endometriosis, which is actually the more common type of actually endometriosis, where it's actually these what we call peritoneal implants or deposits, which are kind of on laparoscopy, on surgery, will look like little areas of gunpowder on the actual surface area of the pelvic regions. The other more significant, I would say clinically, is actually the deep endometriosis. And that's where it's actually in the rectosigmoid, or what we call the anterior compartment, which is actually in the bladder area. Endometriomas is the ones that are described on the internet as being chocolate cysts. And that's just because of the color in which they look like when we actually, unfortunately, puncture them. And like I said, they do represent a significant of patients actually when we see them on scan, and obviously at operations. Once we see an endometrioma, that should actually ring alarm bells for us and actually say we should be starting to look elsewhere for any obvious other signs. Next part. Endometriomas can be multiple. They can be on the left side, they can be on the right side, or unfortunately on the both sides. And like I said, once I see that on an ultrasound scan, it is definitely saying, yes, you got endometriosis. The question is extent. Next slide, thanks. Yeah. And so what you can see here, now I'm going to see is, actually I'm not too sure if you can see that on there in regards to my pointer, my apologies, but on the left of the screen there, that's a classic looking endometrioma. We call it a ground glass appearance to it. And as you can see there in the surgical slide, sorry, we should have warned you, there may be some things that might be quite, well, normal in the sense of they're humans, but they're surgical actual specimens. That's actually showing on laparoscopy the actual chocolate kind of internal contents that you can see there on scan actually escaping from an endometrioma. Next slide. So, okay, thanks. Superficial endometriosis, as I said, this is the most common form of actually endometriosis. It affects approximately 80% of patients. Unfortunately, because it's usually quite what we call a flat lesion on ultrasound, it actually is very difficult for us to see it on, sorry, it's a flat lesion. It's very difficult for us to actually see it on ultrasound because ultrasound can see things with volume. That's what it's designed to look for. However, we are trying to develop techniques to try to give us a better hint in regards to any type of if there's any features for superficial endometriosis. One of them is actually looking for mobility of the actual organs of the pelvic region to see how well they move. And obviously, do we have what we call site tenderness? So when we actually push on the ovary, for example, does that mimic the pain that you actually have? Next slide. Deep endometriosis is defined clinically, or I should say histologically, meaning once they get it to the lab, an endometriotic lesion that has a depth of more than 5 millimeters into the peritoneum. What it does for us, actually, in regards to the pathology of the condition, it actually causes bleeding. That bleeding leads to fibrosis. That fibrosis leads to scar tissue or adhesions, and that starts to distort the normal anatomy, and that's what causes actually, I guess, the pain due to the fact of destruction and malformation. It does account, again, for a fairly significant amount of actually cases of endometriosis, roughly about 15 to 30%. Next slide. But it's not that easy in the sense of if you're not looking for it, you can totally miss actually seeing a deep endometriosis on ultrasound scan. Here on the ultrasound, what we can see is that smaller lesion there at the top, that little black kind of blob is actually endometriosis on what we call the uterosacral ligaments. Now, the uterosacral ligaments is actually the two supporting ligaments to the uterus. And they are the most common area that we see actually endometriosis start from. Just below it, you'll see this kind of slightly crescentic kind of area there. And that's on the surface area there. That's the bowel endometriosis. And that's on the surface area of the actual bowel. And if you're not looking for this, you can actually miss that. It looks big on the screen itself, but when we tend to do most of our scan actually a little bit more superficial from that area. Adenomyosis, as Jess said, is actually another condition we can look for on ultrasound scan. Yes, it is a benign gynecological condition. It's not cancer. It's commonly diagnosed, obviously, in ladies in the reproductive age period, between 40 to 60 years of age. And we're not too sure of the actual theory of how it's created. We don't know if it's actually coming from external deposits of endometriosis going into the uterus, or is it coming from within, from the endometrium or the cavity into the actual muscle layer, or if there's seeding from when we were actually made way back in the womb type of thing. But the most common thing in regards to adeno is actually what it does, and it actually causes heavy periods, painful periods, and it can also actually accentuate the actual painful intercourse. Majority of people should follow, I guess, a series of guidelines and try to actually look for it and for the diagnosis of it. And one of those is actually made from the MUSA guidelines, which was a journal article which was published, I can't remember exactly now, but I think 2018. Now, when we see adenomyosis, as we said, we should also look for endometriosis. And if we see endometriosis, we should look for adenomyosis. Okay. And next slide, please. Sorry. This is actually what we call a coronal plane of the uterus. It's as if I could actually cut you in half and open you up like a sandwich. I'm looking at you on that type of plane. The lovely little kind of slightly triangular shape there, I call it the fishtail. My sonos call that actually the martini glass. You tell me who's actually the drinkers. But the actual fishtail is the normal uterine cavity. But you can see just surrounding that, these little circles actually. And those are actually endometrial deposits into the muscle layer of the uterus. They're not meant to be there. And this is actually a pathognomonic sign for adenomyosis.
Okay, so when we look at the role of ultrasound in endometriosis diagnosis, historically there was a belief that endometriosis was not seen on ultrasound and only able to be diagnosed by laparoscopy. This is a myth. Endometriosis can diagnose 2 out of 3 manifestations of endometriosis, the endometriomas and deep endometriosis. So not only have we found out that endo can be diagnosed by transvaginal ultrasound, advances in imaging capability have led to recent international guidelines suggesting laparoscopy is no longer considered to be gold standard for diagnosis of deep endometriosis. Transvaginal ultrasound should be used as the first-line diagnostic tool. However, laparoscopy should be considered if transvaginal imaging is negative, as superficial endometriosis remains difficult to detect. So from its initial origin, this is a quote from a paper published in January 2024, stating that from its initial origins as a tool to help reduce the incidence of repeated surgeries, endometriosis transvaginal ultrasound has now evolved into a means of providing non-surgical diagnosis of endometriosis, delivering validation of suffering to those patients. I'm still going. So what is the difference between a standard pelvic ultrasound and a specialised endometriosis ultrasound? So firstly, unfortunately, not all ultrasounds are the same. A standard pelvic ultrasound will assess the uterus and ovaries easily and easily detect endometriomas, but will often miss deep endometriosis in the structures outside the uterus. A specialised endometriosis assessment extends beyond these areas to assess the bowel, the bladder, the supporting ligaments in the anterior and posterior compartment. If these structures are not assessed, deep endometriosis will not be seen, and this is a common reason that this disease is missed on ultrasound. As a result, a standard pelvic ultrasound is not geared to assess for deep endometriosis. A specialised endometriosis ultrasound is an expert-led endometriosis assessment that is performed by trained specialists. We use dynamic techniques to assess for mobility and adhesions and can identify with high accuracy deep endometriosis on the bladder, bowel, and supporting ligaments of the uterus. These are the uterosacral ligaments. We use a systematic approach applying the 4-step IDEA consensus.
So the IDEA consensus, as you can see, was actually a group of people that got together to try to standardize the approach to actually endometriosis ultrasound assessment. Before that, we had lots of ideas of how we could approach it, but this is one way of trying to get all the bodies involved that had special interests, mainly European and actually Australians, to try to standardize also for reporting as well. And so it suggested, next slide, thanks, that we should approach it in 4 different steps. I would say that the routine step or the standard ultrasound is actually step 1, the first step. And that's what everyone has been doing. Routine evaluation of the uterus and the adnexy. We did not do actually the plus part, which was actually looking for adeno and looking for the presence or absence of endometriomas unless it was obvious. But it was the extension from there that I was doing for years, actually the second step, which is actually looking for what we call soft markers or site-specific tenderness and ovarian mobility. And that's actually using the actual transvaginal probe to push on the actual ovary to see how well it moved. The addition, actually, the IDEA consensus actually suggested was actually going beyond even that. So going from the uterus and the ovaries to actually the adnexal region, going into a little bit more further out. And that's actually where we looked at the uterus to see how well it moved. Did it have what we call the sliding sign? I prefer to use the presence or the absence of it. They suggested negative and positive, but that kind of made my brain hurt a little bit to try to figure that one out. But the next step, the 4th step, is the most important one to look for deep endometriosis. And that's when we looked at what we call the anterior compartment, which is the bladder, the ureters, and then the posterior compartment, looking at the bowel, the uterosacral ligaments, and then going down to the rectosigmoid area. Next slide, thanks. Sorry. And so detecting that deep infiltrating endometriosis or DE is a skill that requires obviously advanced training, and it benefits obviously from feedback. It's got a very steep learning curve. It's suggested that you need approximately 40 scans to try to get proficient in actually doing the scan. I would actually argue that you need probably a lot more than that afterwards to actually recognize what it is that you're seeing. The other thing is actually specialized endometriosis assessment must be reported by an expert that actually has the competency to actually interpret those images that they're seeing in regards to on the ultrasound onto a report for your caring doctor as well. Next slide, thanks.
So, how is the ultrasound performed? The assessment is performed transvaginally with an internal probe, sort of like a slender camera. For your comfort and to optimize our views, you'll be asked to empty your bladder before the internal scan. A sterile probe cover is used, and with your consent, the camera will be gently introduced into the vagina. During the examination, the camera is moved with varying pressures and different angles. The sonographer may also put their hand on your stomach and apply pressure to further assess for mobility of your uterus and ovaries. How long will the ultrasound take? The sonographer will carefully assess the structures for any evidence of endometriosis or deep endometriosis. The entire ultrasound assessment will take approximately 30 to 45 minutes under the guidance of those well-established protocols. And depending on the ultrasound practice, the reports are then sent to the referring doctor in a timely manner. At QFW, the results are discussed generally with the patient on the day, and the report is sent to the doctor usually in the same day as well. And this specialised ultrasound should only add 10 minutes to the examination time. So this clip is courtesy of a former colleague and mentor, Dr. Sophie Pearsons, down in Victoria. And it just really depicts that historically, are we playing that? Sorry. Gynae examinations involved assessing the uterus and ovaries by performing the ultrasound with the probe in the anterior vaginal fornix. Now, I don't have a pointer here, Jackie. Can you point to where the anterior vaginal fornix is? And so for an advanced specialised endo assessment, the probe needs to be placed in the posterior vaginal fornix for there to be any possibility of identifying pathology on the bowel, the rectum, the uterosacral ligaments, and the posterior vaginal wall. So that, Jackie, have you got a pointer?
No.
Oh, okay. No worries. Actually, do I have one? You can't see. No, that's okay.
No.
Okay. Oh, good. Moving on.
Next slide.
So, yep. These are two examples of endometriosis that would be unable to be seen if a specialised endometriosis ultrasound wasn't performed by moving the probe into the posterior compartment. If the probe remained in the anterior fornix of the vagina, these nodules, the uterosacral ligament nodule and this bowel nodule here, would have been missed. So fairly significant pathology there, especially that bowel nodule. Over to you, Jackie.
Yeah. Next slide. Sorry. Yeah. So how can a specialized endometriosis ultrasound affect your management or your treatment? Well, what it does is obviously allows for who your referring doctor is to actually triage to send you to the, if you need surgical treatment, to the right level of laparoscopic surgeon. And reduce the need, hopefully, for repetitive surgery, because in general, we would say that the first surgery that you have should be the best and hopefully the last surgery that you have. But we do know that obviously surgery in general does cause scar tissue, but what we're trying to prevent is obviously reoccurrence of the disease. If we can actually identify deep endometriosis, then the question is actually the level of the laparoscopic surgeon that's going to be taking care of you. If we're finding that there's something that we might be able to manage otherwise, sorry, I'm going back one slide. So sorry, Ash. Thanks. We might be able to actually send you on to actually pelvic pain clinics instead to try to minimize some of the actual I would say the synergistic effect of pain that's being created by the actual pathology with your actual body's reaction to that and how you're coping. We want to reduce the impact of on fertility, and obviously earlier diagnosis means that we can get you sent off for fertility questions or conversations a lot earlier than potentially a lot earlier so that you can have better management. Okay, sorry, next slide, thanks.
So I have all the symptoms of endometriosis and I am having a laparoscopy. Do I really need an ultrasound? Firstly, we need to say that there is no relationship between the severity of the symptoms and the extent of the disease. The aim as healthcare professionals is to reduce the amount of surgeries so as to reduce the amount of scarring and adhesions and damage to the pelvic organs that can be acquired through surgery. For many patients in the past and still the present, surgical treatment of endometriosis has required 2 or more laparoscopies. The first procedure, often performed by a general surgeon, a diagnostic laparoscopy, considered to be a look and see. If severe disease was seen, the patient was then referred for a second procedure, a laparoscopic excision, with a multidisciplinary team if needed, for example, a bowel or bladder surgeon. The presence of bowel or deep endometriosis suggests an advanced laparoscopic surgeon should be performing the operation as opposed to a general laparoscopic surgeon. So prior to surgery, a transvaginal ultrasound has been shown to have increased sensitivity in detecting deep endometriosis compared to diagnostic laparoscopy. This non-invasive approach allows for mapping of the disease and may reduce the need for diagnostic laparoscopy and reduce surgical surprises. So you do need an ultrasound. 1 laparoscopy with a multidisciplinary team is our aim. So this article back in 2021 has shown us that when it comes to bowel endometriosis specifically, transvaginal ultrasound preoperatively can accurately replace diagnostic laparoscopy as a preoperative workup. So a sensitivity for laparoscopy being 3.7 to 5.6% compared to 96% sensitivity for ultrasound. Pretty significant. So these images are the care of a Canadian friend, Dr. Matthew Leonardi, a sonologist, a laparoscopic surgeon, and an endo guru. In his slides, he shows us that without a preoperative transvaginal ultrasound, even the best surgeon cannot visualize deep bowel endometriosis. So the slide on the left, the ultrasound image is an image of a deep rectal endometriosis. And the laparoscopic image is showing that there's absolutely no indication that there's endometriosis underneath that peritoneum. So the question is, if you're not having an advanced ultrasound prior to surgery, will your deep endo be missed?
So, can a normal scan rule out endometriosis? Not with absolute certainty, I'm going to have to say, is the short answer to that. And that's because of the fact of the limiting effect of diagnosing superficial endo by ultrasound. Because it is the more common type, it's not easily seen on scan. The severity does not actually correlate with these symptoms. It's actually really, we can't rule it out. So if I say there's a normal ultrasound scan, I'm not saying there's no endometriosis. It's just saying I can't see any actual ultrasound features to suggest it. We do obviously try, to manage. We suggest that managing your symptoms is not the ultrasound's job. If the symptoms can't be managed, then laparoscopy may still be necessary then. Next slide, sorry. So I've had an ultrasound that confirms my endo. Do I still need surgery to confirm my diagnosis? I think on that one, like I said, though it's actually a very accurate, non-invasive diagnostic tool, I would suggest that if you talk to my gynae colleagues, they will say to you that you do need to confirm with laparoscopy. I would say that it depends on what your goal is. If it's fertility, then maybe we need to actually aim for that first and then see how your symptoms are, and then come back and circle back to your endometriosis and see how that's been affected by what by your initial goal in regards to fertility. Yeah, sorry, apologies. Jackie.
Okay. So another question. When is the best time to have my ultrasound? A specialised endometriosis assessment can be performed at any time in your cycle. However, if there is any optimal time, it may be just after ovulation when there is a physiological fluid released from the follicle. This appears in the pouch of Douglas, which can assist delineate structures and help assist assessment of mobility. You also, however, need to consider your pain and individual comfort level when you want to have your ultrasound scan. So it's helpful to have it around ovulation, but not essential. Will the ultrasound be painful? If you've never had penetrative sexual intercourse and have not used tampons, a transvaginal scan is still possible with a skilled sonographer with your consent. Some patients do experience tenderness. Options include pain relief prior to their appointment, pelvic floor physiotherapist to help with relaxation techniques. Some women are unable to tolerate a transvaginal scan due to intense pain, however. So an MRI is an alternative, but it's not a dynamic study, and we have trouble assessing if the pelvic organs are stuck due to adhesions related to endometriosis. How will I feel after my scan? After the transvaginal scan, some patients can experience tenderness. This is considered normal. Sometimes an examination can recreate or exacerbate your pain. This will usually resolve after the ultrasound, and pain relief can be used to alleviate these symptoms. Some women can experience light spotting. This is also considered normal. And also some women may feel emotional and anxious after a diagnosis of endometriosis and ultrasound, as finally their pain has been validated. Whereas some women will feel disappointed if the ultrasound is normal. Once again, there is an emphasis on the inability to visualize superficial lesions with transvaginal ultrasound, and that the severity of the disease does not correlate to the symptoms. I mean, we've seen many patients in our clinic with severe disease who we put the probe in, they have absolutely no pain at all. And then there's patients with no obvious endometriosis, and they're in absolute agony. So, once again, the severity of the disease does not correlate to the symptoms.
One of the other questions that we do ask or get asked is, what happens to my endometriosis actually when I reach menopause? It doesn't disappear. It is still there. What happens is that due to the fall or the decrease in your estrogen levels, the endometriosis itself does not actually continue to proliferate as much as it had prior when you were actually in your reproductive system or stage, I should say. So we do actually still see endometriosis actually in postmenopausal women. Approximately about 2 to 5% of women will actually still have ongoing symptoms even after menopause. The previous history of actually endometriosis is actually saying if you actually get onto some HRT, which has some estrogen in it, will we actually potentially reactivate some of those cells there, which is quite, well, unfortunately, not uncommon. And therefore, the question is, and we don't really have the answer to this quite yet, is what do we do once we actually hit menopause? If you're asymptomatic, do we actually continue monitoring you every year, potentially? There is actually no set protocol as to what to do postmenopausal at this point in time. How do we support patients with pelvic pain? I think it's important to note that it should be the patient's symptoms that are managed, not the ultrasound results. The patient's pain needs to be validated, and the managing of this pelvic pain and endometriosis requires obviously a very much a multidisciplinary approach. We're looking at laparoscopic surgeons, we're looking at pelvic pain specialists, we're looking at allied healthcare professionals such as pelvic floor physiotherapists and GPs that actually have a special interest.
So in summary, little dot points here. ultrasound should be used as the first-line approach for non-invasive diagnosis of deep endometriosis. Endometriosis assessments must be performed by trained specialists and also needs to be reported by trained specialists. Transvaginal ultrasound cannot rule out all types of endometriosis. The symptoms must be managed, not the ultrasound. And the challenge is to implement and encourage correct training for sonographers and also ensure specialist assessments are reported by specially trained doctors.
So we do thank you for your time. Are there any questions?
Thank you so much. I, for one, have my mind blown. So I'm sure people here will also be in a similar situation to me. That was so informative. So thank you so much for sharing that information and just being honest as well. We don't have all the answers, but there's certainly a lot of people and some online here as well who are really working towards those next steps. We do have a number of questions that I will throw out to you and just encourage everyone to feel free to pop into the Q&A. You can do so named or anonymously. You are very welcome. So there are really two key points. So, you know, the guidelines have changed. We've heard for many, many years that the diagnosis gold standard has been for a laparoscopy to be diagnosed with endo. And we were all very, very well-behaved patients, weren't we? We went and did that. And we have data now because 7 years ago, we didn't have the data that we did. So we were, you know, we actually have some really good information to back, you know, all of these different options. And I believe only a couple of years ago, a recent paper said that only 40% of patients that had a laparoscopic surgery for endo found some sort of symptomatic relief. So the 60% of patients still did not have a symptomatic relief after surgery. And we'd really need to bring in those teams if we can afford it. And another key point there to talk about is, yeah, like you say, the lesions in the body does not equal the amount of disease. Sorry, the lesions and the disease doesn't equal the amount of symptoms that people are living with. And we hear that all the time. And particularly when people go for surgery, if they are going for that investigation laparoscopy and they're opened up and it's just completely overwhelmed their entire pelvic area, they need to be either calling teams to get backup, bowel surgeons, urologists, or they're put back on the wait list and rebooked. And that's quite significant on the body to then go back for yet another surgery and go through that process. And so taking the chance to get an ultrasound through someone who is specialised and knows what they're doing to map out that plan going forward into that surgery can be quite powerful as a patient to know what's going on, prepared, but really better inform that care. So that's just really excellent as well. We have a couple of questions. So one that you have already answered there, but there was a question that came through to say, do you need to be in a certain stage of your cycle to have a scan? The gynae has said that it's best to have it done between cycle date 14 to 21. You mentioned before about it's best around ovulation. Can you explain why they say that?
I think that was a slide I did actually, and that was to do with the fluid that can be released into the pelvis when you ovulate, which can help to delineate these structures, especially the uterosacral ligaments, and can also help to show the organs sliding off each other, so the uterus sliding and the ovary mobility as well. But it's not essential. We do it at any stage in the cycle, to be honest.
So there's a little more lubrication.
Yeah.
Yes. But I would say if we could have a preference in regards to the timing in your cycle, it's actually best not after actually ovulation, as in the before you have your period, because we have this corpus luteum, which is the cyst of ovulation. If it actually has hemorrhage within it, it can look very similar to an endometrioma actually on ultrasound scan. And because we're doing a spot diagnosis at a certain time, it's harder for us to discern between something that's actually pathological, meaning an endometrioma, versus something that's physiological. And so sometimes we will actually suggest that they come back at a different time period in their actual period, and just after actually their period has actually occurred, sorry about using the two words periods there, but just after the period is actually also not a bad time period, because at that time we know there's actually no physiological cysts that should be actually present on scan. Okay, everything should be back to a plateau or a pre-ovulation state on the ultrasound. So it does help us a little bit. I must admit, at ovulation, it helps us a little bit more to actually look for the adeno, because some of those glands can be a little bit more prominent on scan just because of the estrogen that's in the body itself. So if I had a preference, I'm going to say the first part and the ovulation, but I would say the second part. The confusion is actually just purely with actually if we get a corpus luteum that has had hemorrhage in it, a bleed in it, it can look very similar. And therefore we want to minimize us overcalling, because we are geared to always look for endometriosis. All our scans in regards to our approach to every patient that comes through the door is actually, we do a gynae scan that is inclusive of endo. We don't make it a separate special thing. We don't charge extra or anything like that. We feel that every patient should actually have their whole pelvic region actually looked at when they come in.
Yes, it should be part of the routine gynae scan. It should just be part of every pelvic scan that patients receive, to be honest.
Do you ever pick up someone who may not have come in for endo or come in for a completely different reason, and then they found you found endo? Is that a common thing?
Absolutely. We've
Yes.
picked up a very large bowel nodule on a pregnancy, actually, a lady that came in 6 weeks pregnant. Just, I mean, you couldn't miss it, to be honest. It was 4 centimeters or something like that. So yes, we do. But we do look in the posterior compartment with every patient that comes in for a pelvic examination. Clearly not when they come in for a 20-week obstetric ultrasound, or but
No.
yeah, it's part of our routine gynae scan.
And
Such powerful information.
And even if you've had a previous scan that was done elsewhere that stated that they did not see actually any evidence of endometriosis, even if it was done 2 weeks ago, we will still do this exact same scan on you, and we will still assess you for endometriosis. And it's a little bit sad to say, but we do actually pick up some what would be laparoscopically stage 3 to stage 4 endometriosis, when previously they've had a scan that said there was nothing there to be seen.
It's a perfect segue into a question in the question Q&A. Someone's had a trans-abdominal and trans-vaginal ultrasound in 2023 that found no deep infiltrating endo, or DIE, but in their laparoscopy last year they found heaps and was completely missed by the ultrasound. So they were just wondering what factors might have been affecting this, and if it's worth getting more done in the future.
I would say it depends on where you're going. One of the things I was going to suggest is that when you book in for an ultrasound scan, that you actually ask some questions, because this is for you and you need to have that information. Is actually ask the place, do they do endometriosis ultrasounds? Is it routine for them? And I would also very cheekily maybe also ask them, how long is the actual gynae scan expected to last? If they say to you it's about 20 minutes, then I'm going to say they're just doing a routine standard ultrasound scan gynecologically. They're not doing the extended dynamic assessment for you. It is because of the time that they've given. Most gynaes that are going to do an extended endo scan will be longer than 20 minutes, 30 to 40, if not more. And so that's one thing you have as a little bit of power back to you to kind of discern potentially the quality of the scan that you might be receiving.
And as we saw in that that clip with the probe, if the probe is not put in that posterior compartment of the uterus and the posterior vaginal wall, those structures in the back of the uterus and behind will be missed. So the bowel endometriosis, the uterosacral ligament endometriosis won't be seen at all. So it is really important.
Is it possible to see endo on the diaphragm on an ultrasound or a DIE scan?
Sorry to say no. That's too high up in regards to where the ultrasound can go. And that is very much, unfortunately, a surgical diagnosis. So we should have a hint of that. Hopefully, if you have other pelvic organ endo, We can pick up actually scar tissue ones. So if you had a cesarean section, for example, that you get this little trail that can occur. So you can get actually endometriosis in your scar. We've seen that. We've got one lady who's got actually endometriosis actually in her hernia. So there are some of the areas that are more unusual, I must admit, that we can see on ultrasound, but they're not super common. But above the belly button, that's where it's actually really quite hard for ultrasound to actually come into fore, and that's where MRI is probably much better.
Another comment here, just thanking everyone for hosting such an informative event. They've had a deep infiltrating endo stage 4 DIE involving bowel adhesions as diagnosed by transvaginal ultrasound, and they're just awaiting an MRI for a laparoscopy planning, and wondering if you could speak to the difference in information obtained via the MRI as opposed to the transvaginal ultrasound, and how even that might play out in the planning of that laparoscopy.
I am not a radiologist, so I don't do MRI. But my colleagues in regards to MRI, where they are able to see a little bit more is actually the extent potentially of the actual bowel endo. Also for lesions that we might not have actually seen on scan because of the distortion that the endometriosis can do with the scar tissue and adhesions. If it's actually buried within it and kind of covering it up, it's actually really hard for ultrasound to kind of penetrate through, as in see through into that kind of clump of scar tissue. So that's where we are limited there. I can only, I would say, when I used to do surgery, because I used to do this type of surgery, we used to do something called running of the bowel. And what we would do is actually go from basically run it through and make sure we can find, could we see any other bowel nodules and stuff like that. I can't do that kind of tip to toe type of look with ultrasound. So I will miss smaller lesions, but if I find the main lesion, then that will actually highlight that you need an advanced laparoscopic surgeon that's going to need to have a colorectal surgeon that's nearby. And that may be masked if you couldn't see it superficially on laparoscopy by a generalist.
2 more questions. Do you ever look at old scans? Do you ever receive old scans from patients and look at them and find deep infiltrating endo in those scans?
Yes, absolutely, we do. We've had patients that have been scanned 2 or 3 times previously over a period of time, and nothing's been seen, and they've come to us sort of pretty, in their chronic stage and pretty desperate, and and it can get quite emotional when you do see endo on these patients that have waited so long for validation of their symptoms. You're right, Jess? It is really common, and we do actually we are able to visualize previous images, because that's good for feedback as well, for not only for us but for other practices. So it does happen, unfortunately. So no, it's
That's right. And we're still learning from each other, aren't we? And if you're so open to, providing almost that community of care, approach just to train in other people, and you have both QFG, Queensland Ultrasound for Women have been so wonderful in trying to really, we've had meetings, Jackie, trying to rack the brains about how do we get this out there more. And hopefully we'll start to see that happen. The final question for this evening is someone who suffers from chronic abdominal pain and was diagnosed with central sensitization by a pain specialist. They've not yet recovered from the pain flare from the last endo scan a year ago, and their pain specialist advised against doing another one. We understand you're not a radiologist, but from your perspective, do you think MRI is a good option to assess the progression of bowel endo? There's no option, or the question is there an option of using some sort of GA or a cervical block in an endo scan to help with that pain?
I would say in this instance, then the MRI is actually a very good option because it's non-invasive in that respect. Unfortunately, a cervical or pudendal block actually only desensitizes actually a very limited part of the pelvic area, and it's actually normally to the cervix area, not actually above. where potentially higher up of the uterus in the higher pelvic region, it won't hit that area, unfortunately. We used to do that, obvious, as we were doing instrumental deliveries at difficult births and stuff like that. So it will only numb the area. Yeah, that I would have to say in that particular case, an MRI would probably be the better bet. Because, yeah, if you haven't quite, in regards to the desensitization of the pelvic floor hypertonicity, yeah, we will set it off. We know when it's difficult for insertion. I do recommend to patients, I said, look, you've got signs here of pelvic floor issues. I think you need to go see a pelvic floor physio. That is going to help decrease your pain threshold, or as you say, level. And then maybe we can revisit this at a later time. We do suggest sometimes Valium to patients. Obviously, got to come with somebody to drive you home, you know. But I think if we are looking for progression, then I think that's where the MRI is actually quite helpful to look past that area, because we're not needing the dynamic issue. We already know you've got pain. It's actually trying to figure out, how much has it gotten worse?
Just on the point of Valium, so we often call the pessaries, the Voltaren pessaries, Valium for your butt. Would that kind of do the same thing here as an oral Valium? Would that help at all?
I think the Voltaren, though, yes, it does help a little bit with actually muscle spasm and the tenderness that can happen when we are pushing and actually trying to figure out where the cause of pain is. We need that muscle relaxation. And I would say the Voltaren might not hit that as much as we need it to. And that's where the Valium actually has that extra bit of muscle relaxing capabilities.
Great.
Yeah.
Thank you both so much tonight. What an
thank you for the
absolute
invite.
cracker of an evening. Just so perfect timing.
Champagne. You ended it off with champagne there, Jess.
I know, absolutely. Oh my
One thing,
gosh.
Jess, I was going to say, I think we need to investigate this endo bus a little bit further to reach the rural communities for the sonographers, because I feel like the patients are being done a disservice out in the rural communities. So training of sonographers out there, or even popping a little ultrasound machine on an endo bus and taking it around the countryside.
It's for those that wondering what we're talking about, at the long lunch, the Queensland Roundtable for endometriosis priority setting and pelvic pain priority setting. We were talking about what are some of the solutions to get better access to care, even for our rural and regional areas. And there was a discussion around getting an endo bus where we can pop in some scans, get some things together like they do for breast screen or the Heart and Stroke Foundation. And so, yes, I think, I actually was in Parliament yesterday and mentioned it to Peter Dutton and Jed Carney, and they were really supportive of the idea of a bus. People love a bus. And I think, yes, things like this will just help to bring, I guess, what we say, take Mohammed to the hill. We bring it out to the rural and regional areas where possible. So we will keep working on that. But thank you all so much for joining us tonight. Thank you to Jackie, and also Queensland Ultrasound for Women for your work, your perseverance. And we are really excited to see what these next steps look like. Thank you so much, everyone. Have a great evening.
Absolutely.
We'll talk with you all soon.
Thank you. Bye, everyone.
See ya.